Hi, everybody. Good evening or afternoon or morning, wherever you're watching from. Welcome to our webinar tonight, which is on autonomic dysfunction with a fantastic panel of folks here with us to talk through that. I am Gabi Conacher. I am co-founder of Wishes for Elliot, and Deep Connections is a project of Wishes for Elliot that we just started about 6 months ago that is really focused on working collaboratively within the DEE world with other patient advocacy groups like our friends at FamilieSCN2A, who you will be hearing from today. And bring critical resources and information to families to help them navigate their world a bit smoother and hopefully find some answers, which is why I'm really excited about tonight, because I feel like this autonomic dysfunction may hold some potential answers for us. And so it's something I'm looking forward to learning more about and digging into. A couple of quick housekeeping things. We are recording today's session. It will be up online in a couple days. And all the participants who are not panelists are muted and have video off throughout the call. But if you have anything that you want to share, a comment or a question, please feel free to go ahead and put that into the chat box, or the Q&A is even better. So, and let's see, that's it, I think. Okay, so I'm going to start by introducing you. I'm going to take this off of this. I think everybody knows where they are now. So I'm going to start by introducing our moderator today, who is Leah Schust Myers. She is the Executive Director of FamilieSCN2A Foundation. And she has had a long career, over 20 years, in the healthcare industry and administration, and brings incredible expertise to her role as executive director. And does it not only because she has a fantastic, beautiful son, Ben, who was diagnosed with SCN2A in 2012, but because of the incredible wider community that she's working for, including Michelle, who we'll hear from today, who is also working hard for our families. So, Leah, I'm gonna let you take it away.
Awesome. Well, thank you so much, Gabi. I appreciate that kind introduction, and actually you just did almost everything I had written down, so I don't really have to say much anymore. So I am serving currently as the executive director for the FamilieSCN2A Foundation. I'm one of the founders. I've been lucky to find a path in my life that revolves around my family. So for that, I'm lucky, but for other reasons, I'm not so lucky. My son won the genetic lottery and got diagnosed with SCN2A in 2012, and started having seizures and infantile spasms then. It was shortly after that diagnosis that I became interested in autonomic dysfunction. And it was because I was chasing what were these really weird symptoms that he was having that I assumed were seizures. And I kept taking him in to the neurologist. They would do an EEG, and the EEG would not correlate with any seizure activity. So they said, it's not a seizure. He's okay. It's nothing to worry about. And never really looked into it any further than that. But I knew it wasn't okay, and I felt like it was a bit of a brush off because these movements weren't normal, and he shouldn't have to suffer through them. So after traveling to multiple states, multiple specialists, lots of Google MD research, and ruling out a lot of other easily diagnosed things, I started really thinking about autonomic dysfunction. Ben's episodes are, it looks like he's scared. It looks like he's preparing for a fight, which led me to fight or flight, which led me to autonomic dysfunction. So after that, and many years of chasing this diagnosis, I just decided right then and there that I would do whatever I could to help others not have to go through that long journey of trying to find answers. And so that is, it's very interesting because it's extremely highly reported symptoms in our group in SCN2A. I see it in SCN8A and Dravet syndrome and many of the other genetic epilepsies. yet it's really underdiagnosed. And so I hope that today can shed some light for those of you that might suspect the same thing for your child. So I have the honor to introduce my friend, and she's also the vice president of the FamilieSCN2A Foundation and mom to the beautiful Eliana. Michelle Lewis, take it away.
Hi, everybody. Like Leah said, I'm mom to Eliana, who is a 6-year-old with SCN2A related epileptic encephalopathy. So kind of our journey with autonomic dysfunction. Ellie spent the first 5 months of her life in the NICU, suffering from hundreds and hundreds of seizures a day. And so when we got out of the NICU and seizures kind of calmed down a little bit, she still has daily seizures. But when the seizures kind of relaxed a little bit, we started to see these other symptoms pop up, these other things that were happening. So from about 6 months to about 17 months when we were introduced to Dr. Coffman, while inpatient, our lives were chaotic, to say the least. Ellie's symptoms kind of started out as these fussy episodes. She would kind of cry, but she had this cute little infant cry, and you know, she didn't make a whole lot of other noises. So we just thought, oh, it's no big deal, you know. But the fussiness increased over time, and the crying got louder and got longer. And then we started to see other things occurring with these crying episodes. You know, we would see facial flushing, we'd see dystonic posturing of her arms and her legs, to the point that it was leading to her having muscle spasms. We saw, you know, kind of a high heart rate and things like that, you know, okay, she's upset, she's crying, there's something wrong. So our first path was, is it seizures? Because, you know, when you've got a kid that suffers from epileptic encephalopathy, your first question is always, is it a seizure? And so we did 24-hour EEGs and got to the point where it's like, you know, these aren't seizures. These are non-epileptic episodes. So maybe it's, you know, neurological irritability. So, you know, she has a lot of seizures, has a lot of neurological issues. So maybe that's what it is. But the episodes kept getting worse and worse. And we started to see a tremor start to develop when she was having these episodes. So kind of our journey, I guess, to get to Dr. Coffman, Ellie was having these episodes, and they began to get to the point where these periods of inconsolable crying were lasting upwards of 12 to 16 hours a day. And nobody could give us any answers. So our next route was, well, it's not seizures, so maybe it's GI, maybe it's gastric. So we did a bunch of gastric emptying studies and all these different things to rule out maybe it's, you know, because we started to see some posturing and some arching. So we thought, well, maybe it's reflux. All right. So, you know, we went down that road, went down that path, and really no significant findings, nothing that was really pointing like that would say she would, you know, if she has a little bit of reflux, but it's not enough to make her cry for 16 hours a day. When we were in the middle of one of her extended periods of inconsolable crying, God love my husband, he had her on his chest and was just trying to console her, do whatever, and she was just crying and there was nothing we could do about it. And she ended up having the spasms in her legs got so bad that she actually fractured her femur. And we were sent inpatient, obviously hospitalized for that. And it was during this series of hospitalizations for the fractured femur that we got onto Dr. Coffman's service. And were introduced to this idea that maybe these random symptoms and these random episodes weren't nothing, that they were something. And that's where we got on this path with autonomic dysfunction and some of the issues that go along with that. And I kind of forgot to mention another thing that we saw a lot of was a lot of vomiting. That seemed to be cyclic in nature. So she would go 2, 3, 4 days and not be able to keep anything down. And then she would be fine. And we'd go 3 or 4 weeks and she would be fine. And then the cycle of vomiting would start again. So it was causing all kinds of other issues. You know, she wasn't gaining weight and a lot of other problems. But now that we're treating the autonomic symptoms, a lot of those things have kind of gone by the wayside. And she's a much happier, healthier 6-year-old that really wants to go to 1st grade. So.
Thank you so much, Michelle. It's extremely validating to hear somebody else that has shared a journey similar to ours, and I'm sure those listening feel the same way. These little weird symptoms are little mystery, medical mystery kids that we have. I remember when Ellie broke her leg, and I will never be able to get that out of my head. It's so severe. This autonomic dysfunction can be so severe that our kids deserve to have it listened to and to be treated. So thank you for sharing. So it's my pleasure to now introduce our expert speaker, Dr. Keith Coffman, Director of the Movement Disorder and Deep Brain Stimulator Programs, as well as the Tourette Syndrome Association of America Center of Excellence at Children's Mercy Hospital in Kansas City. Dr. Coffman.
Hi, folks. So we're going to dive into autonomic dysfunction and the ways that it can present and the anatomy of autonomic dysfunction. So I'm going to start the slideshow here and share the screen. Go.
We're good.
Right, so the title of the talk is Hot, Stiff, and Twitchy, or Cool, Floppy, and Sleepy. It's not a seizure, but it is not normal. So the learning objectives for tonight: identify the signs and symptoms of dysautonomia in the medically complex child, and then be aware of treatment options of dysautonomia, in the medically complex child. So we're going to show you first some videos. So you can see on the left the tremor about which Michelle was speaking earlier. And this is sort of a milder version of an episode. This is the full-blown thing. So this was poor Ellie when things were really dark. You can see that she's incredibly flushed. You can hear that cry, right? That is not a cry of a child who is comfortable, right? That's also not the cry of a child who is hungry or needing to be changed. That is a very neurological cry.
I actually think we're not hearing the crying.
Oh, you're not? Oh. Okay. Well, I can tell you it's very high-pitched. It's very shrill. It is non-stop, over and over every couple seconds. So this young man, you can see already his face is very red, as is Ellie's whole body there. And there is no really sound to this one. This is just a video to show that, you know, why these things can be confused with seizures, because they are clearly not normal activity, but are clearly neurologic in nature, which are seizures. And you can see this young man is twisted almost halfway backwards, and the twisting comes from the extension of the muscles in the back, and you can see he's very uncomfortable. So obviously, and you have a child who has a developmental epileptic encephalopathy, seizure is the biggest part of life. So obviously thinking, could this be seizure? So dysautonomia is called that because it arises from the autonomic nervous system. Neurologists, for the most part, are based in the cerebral cortex, right? We think about the brain, and we don't think a ton about the rest of the nervous system. The autonomic nervous system is responsible for the automatic things like heart rate, respiratory rate, body temperature, gut motility, so moving things through your gut, bowel and bladder control. Can you relax enough to have bowel movements or empty your bladder? Sweating, as Leah said earlier, fight or flight, that is the key sort of thought process, sleep-wake cycles, and sexual arousal. This is, in truth, a simplified diagram of the autonomic nervous system. You're thinking, how in the world can this be the simple version of the autonomic nervous system? And that is because of the fact that it really touches every region of the body. So if you look at the top left and go down from eyes all the way to bladder, the autonomic nervous system innervates every portion of that body. And that is why the symptoms can be so wide-ranging and so confusing. So the key components of the autonomic nervous system is first the enteric nervous system. So this is the nervous system in the gut alone. And there are more neurons in the gut than there are in the spinal cord. So GI issues are a huge part of autonomic dysfunction. And then there's the two competing portions of the autonomic nervous system. There's what we call the sympathetic. So this is the part of your autonomic nervous system that gets you excited, gets you hot, gets you sweaty. And then the parasympathetic, which is we call it the rest and digest system. So calming down and moving things through your gut. From a brain standpoint, command central for the autonomic nervous system is the hypothalamus. So the hypothalamus, we'll show you a picture of it a little bit later. It controls things like hunger, thirst, circadian rhythm, which is sleep-wake cycle, temperature, and everything else. Then we get into the midbrain, which anatomists are not creative people. That's why the midbrain lives in the middle of the brain. It's really that simple. And you get into the two main neurotransmitters that we think about with autonomic dysfunction, which are serotonin and dopamine. So serotonin is sleep, serotonin is pain, dopamine is movement, dopamine is attention focus, heart rate, blood pressure. And then we get into what's called the sympathetic trunk. So down our spines, right outside of the bones of our spines, lives the sympathetic trunk. And this is a group of nerve cells in the autonomic nervous system that communicate to the organs within the body. So I have boiled down autonomic dysfunction into two broad categories. Understanding that some patients may have features of both, but there really are two main categories. So hot, wet, agitated, irritable, and stiff. The wetness comes from sweating and drooling, and then cool, dry, sleepy, and floppy, right? So we'll talk about the hot dysautonomia first, because that's what you've seen videos of so far. When I think about evaluating these patients, what is the history that a patient or a patient's family tells me to say, I've got to think about this? What do the events look like and sound like? Does the patient look uncomfortable? As Leah mentioned, does the patient look afraid? Do they look scared? Do they just look irritated and annoyed? Do they look to you like they wish you could make it stop and you can't? The other thing with this is because the part of the brain that's involved with autonomic control is involved in sleep-wake cycles. Many patients who have these dysautonomic episodes, they'll happen at a certain time of day, or they'll start at a certain time of day. Other things in terms of triggers, are they triggered by needing to have a bowel movement or needing to urinate? Or are they worse when the temperature is hot versus worse when the temperature is cold? As we're talking about kids who have epilepsy, the first step in evaluating these, as soon as you know that these are not a new seizure type coming to mess with your kids' lives, then you say, okay, you know it's not seizure. Well, then what is it? Okay. Whenever I see patients who have this condition, I look for a hallmark feature. I talked about the hypothalamus earlier. So this is a brain MRI. Let me orient you here. This is what we call an axial slice. So this is the front, this is the back, this is the left, this is the right. These little things here that look like eyeballs, that's exactly what they are. They're the eyeballs. So when you look at the hypothalamus, if you go right back between the eyeballs, you see this big rectangular shape. Okay. This shape should not be there. The white is fluid. What should be there is a little sort of slit of tissue. When you see this big wide space in the middle of the brain, that's because the hypothalamus is shrunken, or the brain around there is shrunken, and that's why the control center for the autonomic control isn't working. We're going to switch to cold dysautonomia. So hopefully none of you have had to face this one. This is the much more scarier as a patient parent. Is your child is really, really sleepy, is also cold, is also pale, blood pressure's low, they're retaining urine, they also have constipation, but their heart rate is also slow. So to the untrained person, when they see this, especially untrained physicians, they're like, oh, this child is really sick. This looks like what we call sepsis. The key thing, though, is in sepsis, your heart rate is high. These children have everything saying their body is not functioning well at all, but their heart rate is slow and not compensating for how low their body's output is. These patients, unfortunately, are usually towards the end of their disease state. However, that's not universally true, and we'll talk about how to dig into this. One of the key things that I see in patients who have this is their gut has been so slow for so long that they're getting all of their nutrition by what's called TPN, which is an IV form of nutrition because they simply cannot tolerate feeds through their gut anymore. So when I evaluate these kids, if the patients are clearly in this state chronically, this is all their state of being is, I don't have to go any further. If they're having these episodes periodically, then we get an EEG because you can have seizures that can slow things down. And then I look for that same appearance on the MRI that I showed you earlier. These kids, however, they may actually have a biochemical or neurotransmitter deficiency that's causing this problem. So in the kids who are the cool, floppy, sleepy kids, I get what's called a neurotransmitter analysis. So this is literally looking at the levels of dopamine and serotonin and other things in the brain, because these patients can be treated. So if certain metabolites or breakdown products of dopamine or serotonin are low, this condition is imminently treatable by using medications that increase the output of those neurotransmitters. In kids with DEEs and other conditions similarly, one of the other key things can be a problem with folic acid metabolism. So your brain needs folic acid to run properly. If your brain folic acid level is low, you can get a lot of these symptoms and can be improved by using a type of folic acid that gets into the brain. So if your brain is running slow, your body's running slow because you don't have enough autonomic output, you use medications to improve it. So you give medications to make your body make more dopamine, or you make your body release more dopamine using a medication called amantadine. And then you use medications to give more serotonin. So one of the other giveaways with this sort of slow, cold dysautonomia is you would think that these kids sleep really well because they're so tired, they look so floppy. But when serotonin is low, you don't sleep because you need serotonin to sleep naturally. And there are other medications that you can use to increase things, ADHD type medications as well. The key thing, the key piece that we want to talk about is what's called PSH, or paroxysmal sympathetic hyperactivity. So this has gone by a number of names over the years. It has gone by way too many names to get into. The key thing is you see the extra movement, you see the uncomfortable, you see the red. Okay, so this was Ellie whenever she wasn't treated, and this is her now. So big, I feel so incredibly old. And you see, this is now when it's bad for her. We get a little bit of that tremor that she's had since she was an infant. Her cheeks are a bit flushed, but she does not have anywhere near the level of symptoms that she did years ago. So the key piece that many doctors don't know about, just because it's not something they see, is what's called dystonia. So that abnormal movement that you saw in these children is dystonia. So dystonia is a problem where the muscles that both flex a joint and extend a joint both contract at the same time. This is a very common movement disorder, often gets mistaken for seizure, and as you heard from Michelle, can lead to orthopedic complications, fractures, injuries of that nature. So dystonia with dysautonomia, which is what Ellie has, and the other young man has, is really what the combination of paroxysmal sympathetic hyperactivity is. These are all arise from the hypothalamus, as we talked about. And the key features are this: severe generalized dystonic posturing, so whole body locked and stiff, okay? Just like you would expect to see in a seizure. But you get hyperpyrexia, so that's doctor speak for high temperature, tachycardia, which is doctor speak for fast heart rate, hypertension, which most of us know is high blood pressure, tachypnea, which is fast breathing, and diaphoresis, which is sweating. So you've all seen your kids have seizures. Most of the time, seizure does not have the high temperature, the sweating along with it. And those are the two big things when I'm hearing a history. If I hear high temperature and sweating, the next thing I ask about, and does he or she turn red? Because the skin flushing is the other big thing. As you heard from Michelle, these can last hours upon hours upon hours. The other key thing, and many of my patients who have this have been through this ordeal, is that they've been tried to treat these events with anti-seizure medications, even if the EEG doesn't show anything. They try medications like Ativan, Valium, Klonopin, so the benzodiazepines, and they don't respond to that either. So obviously, from a parent standpoint, seeing your child suffer like that and have doctor after doctor give them meds and not work, it's exhausting, it's maddening, it's frustrating, all of the above. So the key thing with PSH is that once it starts, you can't stop it. As you heard, it'll go 12, 16, 18 hours because it's that most primitive part of the brain, as Leah said, fight or flight, that is firing away uncontrollably and cannot calm down. You cannot shut it off once it's started. So you have to prevent it from starting. That's what the word prophylaxis is, it's prevention. In the world of medicine, there's not a whole lot to say what works to stop this problem, but there is some data. So the first thing is look at the environment. If the room is hot, dial down the temperature. If there's a lot of noise, a lot of sound, make it quiet. And if you do those first two and you see things greatly improve, you know you're dealing with an autonomic issue because seizure does not respond to lowering the room temperature and making it quieter and darker. So when we treat this problem, we use medications that many of you may have not even heard of before. The go-to from the pediatric neurologist standpoint is a medication called clonidine. So this medication works in the brain by decreasing the release of norepinephrine. Norepinephrine is noradrenaline, fight or flight. So you literally dial down the ability to have that abnormal fight or flight response. Sometimes also use medications that some of you may have heard of because it's used commonly in the adult world, and propranolol, which treats high blood pressure and fast heart rate. For the muscle spasms, we use baclofen to reduce the tone in the muscles, and then gabapentin if pain is a trigger. So I talked earlier about what are triggers for autonomic dysfunction. So one of the big things, constipation, urination, that can trigger a significant episode because your bowel and your bladder require normal function of the autonomic nervous system to work. So when it doesn't work and you try to stress the system, everything falls apart and you may end up in a spell just from trying to evacuate your bowels. We'll move on from there.
Thank you so much, Dr. Coffman. We do have a few questions that have come in. There was one that came in via email before we even started.
Okay.
It's a little bit long, so I'm just going to sum it up. It's a little girl with SCN2A epilepsy, early onset, and also diagnosed with hypertension, and it's been pretty severe. She's been medicated for a long time. EKG, ECG, ultrasound, consults with nephrology, cardiology, everything is fine. They can't find any reason for the hypertension. Could this be autonomic dysfunction? And if so, is it normally seen in waves and spikes? Because she's had it pretty consistently for a long time.
So I have had patients who have it as sort of a constant underlying theme. It's not the typical presentation, but it is not unheard of. So I would definitely ask her treatment team to think about that possibility. So when you think about these things, so who do you ask about with this? If you have a neurologist, always start with him or her because they're the ones that are the most likely to have experienced or heard about this before. if you're a neurologist, if you don't have a neurologist or don't have easy access to your neurologist, but you're seeing other specialties, the other specialty that knows about this very well is physiatry, also known as physical medicine and rehabilitation, because they see the same thing after, say, spinal cord injury. You can have the same kind of problem. So those are the two big specialties to ask about it. And what I tell folks, other than this case, when you have things like this, do what Michelle did, do what my other families do. Capture these things on video and show them to everybody involved in your child's care to say, no one knows what this is. Can you please help us?
That's really good advice. The video is super critical, and to keep pushing. Thank you for that. I'm going to read a few more questions that came in the chat. Somebody asked if autonomic dysfunction looks the same in older children and young adults as it does in the babies.
So I might need some clarification on that in terms of what specifically you're talking about. I can tell you the features, whether it's an adult or child across the literature, is the abnormal body posturing, the flushing, the sweating, the elevated temperature, the fast breathing, the high heart rate. Obviously, someone who's older is not going to cry like an infant would, but the overall picture of what you see symptom-wise, because there are actually rating scales and criteria out to look for this, all of those other features are definitely the same regardless of age.
Got it. Okay, thank you. I'm going to read another one here. Daughter had has not had an MRI since birth. She's almost 5. Can an MRI image change to show autonomic dysfunction since then? And should we repeat MRIs?
So I'll work the question backwards. If your child is having autonomic dysfunction and they have not had an MRI in some time, say before the autonomic dysfunction started, yes, I would say an MRI at that point would be warranted to see if there's been loss of brain tissue that would explain why the autonomic dysfunction has started. So in my practice and the patients for whom I care, anytime a patient of mine has a new autonomic dysfunction problem, I always get a repeat MRI because I'm looking for changes in the brain tissue that would tell me why that has happened. I think you're muted.
Thank you. So thank you for that. There's been a few questions about duration, let me see if I can just actually read this one. Can you fluctuate between hot and cold dysautonomia?
Yes, I have seen that.
Okay. Is autonomic dysfunction only episodic, or can it be an ongoing condition if the hypothalamus has been damaged by surgery?
So from a surgical problem can present differently. It can be more of a constant problem as opposed to an episodic problem, because the disease process is different when you're talking about a direct tissue injury versus a circuitry problem like an epileptic encephalopathy where the circuit can't keep up. It's much different than if an actual injury has occurred in that area.
Okay, that makes sense. So back to the fluctuating between the hot and cold. If you treat one, can it actually make the other one worse?
So that is a dicey situation. So whenever I'm faced with a patient who has flavors of both, I always start with improving the sort of cold, sleepy one first. And what I do and is I work up slowly to get things back to a normal level. And I don't usually end up having overflow and sort of flooding the system. But the key thing with managing patients who have this kind of problem is low and slow. You start at low doses and you increase slowly, because patients who have this kind of a problem are very sensitive to medications because their brains are working so hard every day, all day to function. So you're only going to run into problems in terms of making the other problem worse if you go too fast and use too high of a dose.
That makes sense. Somebody's asking about status. Is there such thing as a dysautonomia status that can go on for over 24 hours?
I mean, in theory, yes, and honestly, I mean, Eliana, as Michelle said, would have times where she would go nonstop for 18 hours. So in theory, yes. Have I ever seen someone who's had it that prolonged? No, but I'm still relatively young.
You are, yes. Thank goodness, because we need you around for a long time. If there is a dopamine deficiency and Sinemet has caused increased seizures and the child was taken off, is there another safer alternative to use? And what if the patient has low dopamine and low serotonin levels?
So that last question is, I'm glad someone asked that because I forgot to mention that. So we'll talk about, if Sinemet has caused problems. There are many, many other medications that can increase dopamine activity in brain. One that I mentioned on one of the slides is amantadine. Other things such as the psychostimulants can do it. There are also medications that actually slow the breakdown of dopamine. So you can recover dopamine by slowing how rapidly it's broken down. So there are many things besides Sinemet. Sinemet's just the first thing we try in patients like this. So the other question, the question I'm really glad somebody asked is, what if you've got both? What if you've got dopamine and serotonin low? So what I do in that situation, because this is a frequent problem in my world, is I take the patient and all of his or her symptoms and talk to the family and say, okay, these are all the symptoms related to low dopamine. These are all the symptoms related to low serotonin. Which one is causing the biggest negative impact on your child's quality of life? And we'll start there.
Thank you. Okay, I'm going to read a couple more. Do you see this in children with autism only, as well as epilepsy patients?
Are we talking about autism patients who also have a channelopathy?
Yes. Yes, okay. I believe so.
Okay. I am not aware of folks who have a channelopathy and also have this. Theoretically, I'd say it's definitely possible. But I would that would be someone that I would want to take a very good, thorough history on to see, is the autonomic issue a separate issue from whatever the channelopathy is. Yeah, that's someone who needs someone to sit down and take a really good history.
Okay. So a lot of the children that we have seen in our group and some of the other groups like Dravet syndrome, they present with an intolerance to heat. For instance, it can cause vomiting or a seizure immediately. It's a seizure trigger. They just cannot fluctuate. They cannot regulate their temperature.
Yep.
It seems pretty common. Would you consider, and also motility issues, gut
Yep.
motility. Would you consider both of those an autonomic dysfunction diagnosis, or possibly related to just their channelopathy?
So that's a perfect question. So we know that Dravet, in particular, temperature intolerance is a part of that condition. Many kids with Dravet start with having seizures with fever at body temperatures that most other people would not. So temperature intolerance across channelopathies is very common. So I'll switch gears to other channelopathies in the world of migraine headache. Autonomic dysfunction is a part of almost everyone who has migraine. So that sort of mild, quote unquote, mild autonomic dysfunction of heat intolerance and gut motility is 100% part of a channel disorder. What we're talking about with the cases that I described is when that gets to be the nth degree of dysfunction. So yeah, that's a perfect question, and really is incredibly thoughtful.
I wish I could take credit for it, but it was one of our listeners here. So here's another one. Can electrolytes, especially potassium, help increase the autonomic function, especially in overheating or constipation?
So unfortunately, no, because the problem is driven by the abnormal activity in the brain. Changing electrolyte balance is too far downstream from where the problem lives to help. I wish it was something that simple, but because the brain is so isolated from the rest of the body, the brain does not see changes in electrolytes when you give electrolytes anywhere to the extent that the blood does. Just like when you give sugar to the blood, your blood sugar level goes up, but because sugar has to actively be moved into brain, your brain sugar does not rise to the level that your blood sugar does. Same kind of a thing.
Thank you for answering that. We have a family that is an SCN2A family that has a question. She's saying, we dealt with a pretty severe cold autonomic response that led to cardiac arrest. It's now being discussed to have a pacemaker put in. Would this be an appropriate treatment? Can
you read the question again, Leah?
Oh, sure. So this little boy had a pretty severe cold autonomic response, and it led to cardiac arrest, and they're now talking about putting a pacemaker in. Would you think that would be an appropriate treatment?
Based on what I know, I would say to definitely, I would have presented with that patient, I would look at spinal fluid neurotransmitter levels before I would do a pacemaker, because the pacemaker it's gonna keep you safe. It's gonna prevent the arrest from happening again, but it may not be you may be treating a symptom as opposed to the cause from a neurologist standpoint.
That's very helpful. Thank you. One more. My son has episodes when he suddenly is moving very quickly and oddly, and often gets sweaty, lasting maybe about 10 minutes. Could this be an autonomic dysfunction? Does autonomic dysfunction get worse over time?
So I'll answer the second part. Yes, if left untreated, as you heard from Michelle, it definitely gets worse over time if not treated. Without seeing the video of him, I wouldn't be able to say. So as a movement disorder neurologist, it's all about pattern recognition. So when I see the patient, see everything and put it all together, being a neurologist is kind of like being a detective. You know, it's the more clues you get, the better you are able to get to the answer. So I would need to see a video to be able to answer that one accurately and effectively.
Thank you. We totally understand about the detector. That's how we all feel as parents. Let's see. We have, I think, Gabi, what do you think? About 5 more minutes to ask a few more questions?
Yeah, I would say let's get through as many as we can. We've got a lot of questions coming in.
Yeah, and these are all really good questions. Dr. Coffman, there's several that are related directly to certain diseases. Like, do you feel there's a correlation between tuberous sclerosis and autonomic dysfunction?
It would have to depend on how severely the patient is affected by the TS. You know, when we see the kind of autonomic dysfunction that I've been talking about, the disease burden from a brain standpoint is very heavy. And the reason these symptoms arise is because the brain has a problem regulating the automatic functions it's supposed to do. So the more severely affected, the more likely it is to be autonomic dysfunction. And TS can present with such a wide spectrum of severity, but if the child is very severely affected, large seizure burden, really significant developmental impairment, then yes, it's possible that it's part of it. Because I see it in other conditions too. So it's not just the channelopathies that I see this in. I've seen it in children with after drowning. I've seen it in children after traumatic brain injury. I've seen it in children with other genetic conditions. So it's not simply limited to the channelopathies. And I can tell you in all of those other conditions as well, it's just as under-recognized and underdiagnosed as it is in the epileptic encephalopathies.
How about mitochondrial disease? Can mitochondrial disease exacerbate this?
Oh yes, 100%. Yeah, some of the most challenging patients that I take care of who have autonomic dysfunction have it because they have a mitochondrial cytopathy. Yes.
And there's another question, which I think is really a good one, about neurotransmitter levels. Can you check it in blood serum, or does it need to be in cerebral spinal fluid through a spinal tap?
So the absolute gold standard is lumbar puncture, and it's because these compounds, the compounds that are looked for, are very temperature labile compounds. So the right way to do the cerebrospinal fluid analysis is actually a very complex procedure where it's best done early in the day. It has to be done on the first couple drops of spinal fluid. The spinal fluid needs to go in specially prepared tubes to keep the compounds from degrading. The tubes need to be placed immediately onto ice and then FedExed to the laboratory doing the study. If at any one of those steps is not done properly, the results are unreliable. So blood is not used regularly at this point in time. There is, however, technology coming available and trying to see if we can look at the neurotransmitter levels in blood as accurately as spinal fluid. One of the things to understand about CSF neurotransmitter levels is they are at their best in the morning. So you replace neurotransmitters as you sleep. So the later in the day you do it, the less accurate the results compared to the morning as well. So at this point in time, the only way that I ever get it is CSF early in the morning.
Okay. And can it change over time? If you've had it done once, like 10 years, can it change?
Oh, even faster than that. So I have a young man who does not have a channelopathy, but has a really significant problem with autonomic dysfunction. And despite treatment, he continued to do poorly and obtained his levels on treatment, and they were still low. So yes, they can change over time. They can worsen over time. If the history is there, look to do the test again. That's how I think about it whenever I'm assessing all of these kids.
Okay. Are there any online resources to help understand, treat, show medical teams that you can recommend? And also, do you do virtual visits?
So I will share some good, reliable links with you, Leah, and the rest of the folks to share out to everybody else. I didn't have any links pre-prepared, so I want to vet them properly before I mention them out loud. Okay. So the virtual visit, here's a good advocacy platform for those of us who take care, who have medically complicated kids to get behind, okay? So this is a soapbox, and I apologize, but this is critically important. The way telemedicine laws are written and applied in the United States of America right now is backwards. The laws state that the physician seeing the patient has to be licensed in the state where the patient is located, okay? That makes no sense, right? You want your child to get the best care possible. Pre-COVID, how would we do that? We would go to the experts, right? It then doesn't matter if the doctor is licensed in your state because you're going to the doctor. So we need to get the telemedicine laws changed and have it be that all of our patients and families can access the experts in these rare conditions without it mattering in what states they have medical licenses. So soapbox over, but the short answer to that is if you live in the state of Kansas or Missouri, yes, because those are the only two states in which I'm currently licensed. If you live in any other state, talk to your congressmen and senators.
Okay.
Yeah, sorry to interrupt, Leah. Just a quick push here is that last week we actually did a webinar on what people need to do to keep telemedicine available and the advocacy efforts underway. So please check in our resource center, and we've got some links to some advocacy that folks can do, because it's really got to come from families.
Yep, the only way it's going to change.
Yeah,
absolutely. It's critical, and I appreciate you spending the extra time on it. And so, Dr. Coffman, I'm going to move on because we're almost done here, and
Sure.
I want to give Stacy just a couple minutes to introduce the survey.
Yeah.
So when we first started talking about autonomic dysfunction, and I asked you, why is it so underdiagnosed? And you told me it's just because most people don't know how to treat it. So why are they going to diagnose something they don't know how to treat? And I said, well, how can we change that? And you said, we have to get it in front of them. We have to get something published and in front of treating clinicians.
Yep.
And I said, how do we do that? And you said, data. How do we do that? Survey. So we're working our way backwards, and we have a survey that we have been working on. And I'd like to hand it over to Stacy to talk a little bit about that, as she is a student at University of Pennsylvania, and she is taking the lead on this project. Stacy?
Yes. Thank you so much, Leah, for inviting me to speak today. I'm really excited to be able to speak with you all. Like Leah mentioned, I'm a graduate student at the University of Pennsylvania studying genetic counseling, and I've been working on this project as part of that. So this project is in partnership with the FamilieSCN2A Foundation, as well as with the Epilepsy and Neurogenetics Initiative at the Children's Hospital of Philadelphia. And a huge part of our project is looking at the prevalence of non-seizure features in kids with DEEs. And this is including symptoms of autonomic dysfunction. And this is, like Leah mentioned, in order to get the data behind, how many patients is this actually affecting? And to kind of be able to present the facts to doctors helps to legitimize this concern in the medical world. Secondly, we're also looking at quality of life in our survey. And then lastly, we want to see and assess the relationship between the presence of these non-seizure features and quality of life. And, definitely we're hearing from patients that all these symptoms outside of seizures are a huge impact on the day-to-day quality of life. And I think, obviously these disorders have a lot to do with seizures, and treating them is very important, but they're certainly not the only thing that we need to address. And I think the main goal of this is to make sure that, you know, we're treating the child's seizures, but also everything else that's going on for them. And we're asking the families, you know, what is the quality of life implications of all of these symptoms? How is this affecting you? How is this affecting your child? And we're documenting it in the medical literature, and like Leah mentioned, hopefully bringing it to the attention of your child's caregivers and medical team. So definitely keep your eye out for our survey. We're planning on distributing it in September of this year. And I want to thank you all in advance for your participation in the project. We're very excited to take a look at what the data brings. So thank you.
Thank you, Stacy. I really appreciate you taking this project on. It's going to have a huge impact on many, many lives. So once again, I'd like to thank everyone that joined in and took time out of their day to listen in. Dr. Coffman, thank you so much for your time and your expertise. You're amazing. Michelle, thank you for sharing those videos of Ellie and your details of your journey. And Gabi, thank you for setting this up, for giving us a platform to share these super important topics, not only this one, but all the ones that you've done. This is an amazing, amazing setup, and I couldn't imagine being on this journey without you.
Thank you so much, Leah. You said everything I was going to say, so we can switch. You know, I'm just so great. It's amazing to be on a journey with someone as fabulous as you, and thank you for bringing this to the wider DEE community. I think it's incredibly valuable, and we're so glad that you could be with us, Dr. Coffman. Excuse me. Just want to close with one additional note, which is that we will, oops, excuse me. If you can see this, thank you. We have our next webinar is August 12th, which is part 4 of our series on rescue meds for DEEs. And this is a session for you to dig in and either design or update an individualized seizure emergency plan, which really is a tool that you can hand to somebody in an emergency. Someone can pick it up and say, what do I need to know about this child, their seizures, their medications, all of that. So this is in partnership with the LGS Foundation that we've done this series, and we're really excited about that. So please sign up. You can sign up by visiting deepconnections.net website. And before people head out, please do us a favor and take this very brief survey that will show up on your screen once you close Zoom, just to help us be able to serve you better. Thank you, everybody, for joining us. Thank you, Michelle, Leah, and Dr. Coffman. It's a fantastic session. I'm definitely going to be watching this several times again to try to pick it all up. Good night, everybody. Take care.
Bye.